Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Tiffany Hensley McBain. Today's episode is part 2 of a 4-part series entitled Managing HIV in Aging Patients, Answering the Questions. This podcast is part of a comprehensive educational program on caring for aging patients with HIV. This program consists of video logs on individual patient cases, each highlighting challenges rendered by a select comorbidity or set of comorbidities in an older patient with HIV. Today's faculty will refer back to their recent vlogs as they introduce the topics for today's discussion. During this episode, Dr. Jonathan Appelbaum from Florida State University College of Medicine in Tallahassee, Florida, Dr. Howard Grossman from Florida Atlantic University and Midway Specialty Care in Wilton, Manors, Florida, and Professor Jürgen Rockstroh from the University of Bonn in Bonn, Germany, will answer infectious disease specialists' most pressing questions on caring for patients aging with HIV. For more information about Dr. Appelbaum, Dr. Grossman, and Professor Rockstroh, and for a link to their video logs, please visit the show notes for this episode. Now let's get started with a brief introduction from each of our expert faculty on current challenges they encounter when caring for patients aging with HIV in their clinical practice, starting with Dr. Howard Grossman.
Thanks so much, Tiffany, and welcome to all the participants. We're really happy to have you here. Hopefully, you've had a chance to see our vlogs. If not, then hopefully this will get you to them. Today, we're talking about the fact that the proportion of people living with HIV greater than 50 years of age has been increasing globally. And aging with HIV presents a greater burden of comorbidities and treatment side effects than we may have experienced with younger patients. I'm going to talk a little bit about caring for aging transgender patients, initiating gender-affirming hormone therapy. Dr. Appelbaum will talk about caring for patients with multiple comorbidities and or multiple concurrent medications. And Dr. Rockstroh will talk about caring for aging patients with co-infection with hepatitis B and hepatitis C. In my vlog, I talk a little bit about the fact that for a lot of transgender patients, their main concern is their hormone therapy, their gender-affirming hormone therapy. And the most important thing for them is what kind of interactions will they have with the kind of drugs they're using. So there are significant numbers of HIV drugs that have no predicted effect on estrogens. I would note that estradiol pills are not recommended for people who are over 40 years of age, and especially for people who smoke because of the increased risk of thromboembolic events. Conjugated estrogens are also not recommended, and that basic birth control pills are not recommended either. You can see that boosted protease inhibitors especially may have significant impacts, and you may have to change the estradiol dosage. And for androgen blockers, spironolactone, and then the gonadotropin-releasing hormone agonists, as well as finasteride and cyproterine acetate, which is not available in the U.S. For these, you can see basically very similar drugs that are impacted, and you need to maybe change the dosage. Now I'm going to turn it over to Dr. Appelbaum.
Thank you, Dr. Grossman. So I'm going to refresh your memory about my video log. If you remember, my patient was a 72-year-old woman who'd been living with HIV for many years, well controlled on a combination of a boosted integrase inhibitor, but she also had multiple comorbidities, including osteoporosis, hypertension, and mild cognitive impairment. And if you remember, in addition to her antiretroviral therapy, she was taking amlodipine, hydrochlorothiazide, lisinopril, atorvastatin, alendronate, aspirin, and calcium carbonate. And so this brings up the whole issue of polypharmacy in our patients who are aging with HIV. And the geriatricians define polypharmacy as any patient taking 5 or more concurrent medications. The issue with polypharmacy is that your there's an increased risk of drug-drug and drug-disease interactions, and particularly in our patients who are taking antiretroviral medications. In one study of a pharmacist review of medication in over 200 adults living with HIV who were either 50 years of age or older, the mean number of medications was 14.2 as compared, those are the patients with HIV, compared to just a little over 11 medications in our patients who are not HIV. And again, looking at the medications and whether or not they're appropriate or not, over a third, almost 2/3 had more than one inappropriate medication that was prescribed. And so the question we always ask is, adding more medication, is it providing benefit to the patient, or are you increasing the risk of potentially complications? And in fact, data shows that more medications have been associated with greater mortality. So now I'm going to turn this over to Dr. Rockstroh to talk about his blog.
All right. Thank you, Dr. Appelbaum. My first vlog, which was around an elderly gentleman who had newly diagnosed HIV and hepatitis B co-infection. And I talked a little bit about the special issues around treating hepatitis B in the setting of HIV, but also in the setting of a patient who's already older with comorbidities. And particularly, my patient had renal insufficiency. There is guidance from the AASLD guidelines on hepatitis B treatment that indeed, if you have renal abnormalities or bone disease and have a higher age, that would be the indication for using TAF over TDF. Now remember that in the setting of having HIV, you would prioritize TDF or TAF over entecavir because of the dual activity which you use for treating HIV and hepatitis B at the same time. But it's important to remember, particularly when patients get older and they have hypertension or diabetes and slowly develop renal insufficiency, that is a problem with the TDF, and you need to dose adapt. But much better choice is obviously then to go for TAF, which you can give at much lower GFR rates than TDF. So that was sort of my first blog I did. And then I had a second blog, which was around patients with recently acquired hepatitis C. And I think the first important point is to highlight that obviously sex occurs at all ages, so don't forget that people who are getting older still can practice unsafe things around crystal meth use, which is associated with a higher risk of getting acute hepatitis C infection in the context of men who have sex with men, particularly unprotected anal intercourse. Blood exposure seems to increase that risk. And so I walked through a case with that recent diagnosis of hepatitis C and how you can separate a new infection from reinfection and so forth. And also about the treatment paradigm, and the EX guidelines in particular have been very helpful in setting up an algorithm for management of recently acquired hepatitis C infection, which really basically says that once you have your new diagnosis of hepatitis C, that you would then repeat a hepatitis C RNA 4 weeks later. If there's not a 2-log drop, you're very unlikely to clear infection. Actually, clearing infection in the setting of HIV co-infection is very low. It's probably not more than 15%. And then obviously you would want to treat that patient. Now, if there is, and that's the real change, I think, in the guidelines, if there is a high risk of onward transmission because of continuing risk behavior, then you would want to treat right away to make sure that you don't have onward transmission to other individuals. So that's sort of the basic concept here, and it gives you nice guidance of how and when to start DA therapy and which kind of drugs to take and so forth. So I'll stop here. Thank you.
So thank you very much for those introductions to your blogs. And again, I encourage our participants to go check those out on our website. So now we're just going to devote the rest of the time to a question and answer session where our faculty will answer your questions on caring for aging patients with HIV. So please continue to submit your questions. And we'll start with this question from Michael. And he asks, is there an age limit or some other metric after which statins would be avoided? And Dr. Appelbaum, we'll start with you on that one.
I get in the hot seat first. Okay. There really isn't any metric. I mean, I think, I wear two hats, both as an HIV provider and as a geriatrician. I think from the geriatric point of view, there does come a point where we look to see, in fact, whether the benefit of any medication outweighs the potential risks. And remember, we're giving statins either as primary or secondary prevention for things like coronary disease. And if you're giving a primary prevention, you're not looking at the immediate effect of that particular medication, but the downstream effect of that medication, maybe 5 or 10 years down the road. So if you have a 75-year-old and you're trying to prevent something that may happen when that patient is 85 years old, and they have multiple other medical conditions, there may not be any benefit to the use of a statin in that regard. On the other hand, if a patient's doing well on a statin and they're not having any issues, or you're not concerned about drug-drug interactions, many of us would just go ahead and leave the patient on the statin. It's fairly well tolerated. We always run into the problem, and at least in my practice, my older patients tend to have more side effects from statins, including the myalgias and those sorts of things. So again, that would be a downside of a statin, and I might look to perhaps reduce it. So I'm not giving you a definite answer, but I think we always should be looking at all of the medications a patient's on and trying to look at the risk and benefit of each one of them. In fact, whether or not they still are indicated, or whether we can do something called deprescribing. So I can defer to my colleagues if they have any other comments.
Oh, I'd agree with you, John. I think we always have to decide whether we're treating the patient or whether we're treating guidelines or treating ourselves. And I think you did a great job of explaining it. I think we're in this controversial period, so it's also really important to talk to the patient and see what they're willing to do and what their own risk assessment is.
I might add that my oldest patient is 91 years old. So if he would be 75, he might, if I would have given him a statin at that point, he probably would have benefited potentially with regard to cardiovascular prevention. In the German context, I have to say that our cardiologists are very active giving statins, so that's a very strong cardiology-driven thing. And one of the issues is that they give everyone simvastatin, and simvastatin obviously has a high potential for drug interactions, in particular with boosted PIs. And so as an HIV physician, you're constantly sort of switching and changing the statin because the cardiologist is just not willing to give something else than simvastatin because that's the cheapest choice. And I think that's one of the important things to remember, because statins are given in many different contexts, that you always make sure that there are no drug interactions with your given HIV treatment, because I think that's something which occurs quite often.
I think I agree, and I think at least in the United States, I think the cardiologists also kind of drive the statin issue. The good news is that simvastatin is not on the preferred is not one of the preferred statins according to the guidelines. So we tend to use a lot more atorvastatin or rosuvastatin, and now with the availability here of pitavastatin, which has virtually free of any drug-drug interactions, I suspect that many of us will be moving more towards that medication.
Great, thank you for that discussion. So we'll move on to another question from William. He asks, are there any data on whether older patients are at different risk of weight gain versus younger patients after switching or starting an INSTI or TAF-based regimen? And Dr. Grossman, we'll start with you on that one.
I think there's more data on the male-female difference than there is on age-related differences. So much of this data has come from Africa, and I think you're dealing with often a younger population there. So I think we really don't know the answer to that. Well, ask my colleagues.
Yeah, maybe I can chip in here. I mean, remember that some of the data around TAF and weight gain also comes from the PrEP trials, right? And that's on average a younger patient population.
Right.
And we did see some weight gain there as well. I think though the whole question who gets the weight gain is still a little bit unclear, because obviously other than sex having potentially an impact. Obviously, there also seems to be an ethnic element, particularly the patients from the famous ADVANCE trial, which was really a lead trial, which highlighted this issue in particular, with almost 12 kilogram of weight gain over 2 years in females in particular, was worrisome. But that has not really been reproduced in other patient populations, and in the large phase 3 trials which were registrational for dolutegravir, bictegravir, we didn't really see the same amount of weight gain. So I think there's some open questions remaining, but age was really among none of the prediction factors for more or less weight gain.
Okay, thank you. So we have a question here on kind of care coordination. So how would you best manage an HIV patient with multiple other comorbidities, each requiring specific treatment? So Professor Rockstroh, I guess we get to start with you on this one.
Yeah, so I think that's a great question, because in Europe, at least, there's a strong quest to have multidisciplinary teams, and because, you know, not everyone is trained to take care of diabetes, hypertension, coronary disease, bone disease, all at the same time, and that can be a real challenge. So if you kind of set up your clinic with links to other specialized doctors, that is probably always the best way forward. But we shouldn't forget that in HIV, we still have to deal a lot with stigma, and a lot of people don't want to go somewhere else. So at the end of the day, we all end up sort of treating hypertension and diabetes, at least to a certain degree. But I think we do have to appreciate that there are other specialties, also when it gets to more advanced kidney disease and other issues, where we really have to rely also on other disciplines.
I agree, and I do think that many specialists are really afraid of HIV patients. They just automatically throw their hands up and say, "I don't know anything about those drugs," and you know, it's like, read a book. You can learn. You know, personally, I can't live without a good, reliable drug interaction calculator. I just think with so many of these patients on polypharmacy, you really need to. You need a system that actually can look at all those drugs together, rather than relying on just memory.
Yeah, and
I think I would. Oh, go ahead.
Yeah, I really have to re-emphasize that, because like one of the more commonly visited doctors is an orthopedic surgeon, right? Because everyone, when they get older, they get hip pain or knee pain, and a lot of the orthopedic surgeons give steroid injections, and they really don't have the time to look up any drug interactions. So basically just give the injection, and whether you're on a PI or not, but if you get a steroid injection and you're on a PI, you're going to get Cushing disease and all kind of problems. So what we always try to say to our patients is that, you know, if the doctor you're going to doesn't have the time to look it up, we're very happy to do it for him or her. And that at least leads to people calling us, can I take this antibiotic? Can I take this injection? Can I get this? And I think because you can really prevent some severe interactions and you know, real harm to the patients if you make sure that interactions are looked up.
I was going to say, I would put a plug in for the fact that HIV, for many of us, we're primary care physicians. We take care of everything plus HIV. So I'm going to put a plug in for us who are really primary care physicians first. But I'll also say, when I put on my geriatrics hat is, and I think what the questioner was asking is, you know, how do you take care of all of the other issues and HIV in your patients? And I think we have to do what we do with all of our patients with chronic diseases. We have to prioritize, and realizing that you can't take care of everything in one 15 or 20-minute visit. And so maybe bring the patient back, or relying on your healthcare team to help with you know, some of the other issues, and trying to deal with the, you know, most important issues first, while not forgetting preventive care. And again, I think that's where sometimes using your advanced practice clinicians, your nurses, your social workers will help.
And in the Yeah, sorry. In the EX guidelines, I just want to highlight that there is sort of an assessment of what you should do to check for comorbidities. And really, if you're not very trained in these areas, because not everyone is, a general practitioner, then you have really a flow chart of like, when do you have to, when is diet and physical exercise enough? When do you have to think of pharmacological interventions? And they have really great algorithms for lipid control, hypertension, diabetes, and everything. So that really helps a lot. So I can only refer you to the EX guideline because that's the only guideline I know which has this very huge section of comorbidity management plus all the interaction tables as well.
And I think one of the big challenges with the time limit that we have in primary care is getting patients involved in the process and teaching patients about how to manage their visit themselves, so that they don't walk in with 15 different problems. But they prioritize, and they sort of teaching them how we think, so that they know how to have the best impact in a limited amount of time. I wouldn't underestimate doing that, spending that time with patients to teach them.
Okay, thank you. And this question kind of goes along with that one. Someone submitted this during their pre-registration, just asking about non-AIDS comorbidities and what you think is the best way to prevent them as your patients age. So, Dr. Appelbaum, I think we're back to you.
I would, making sure that you are screening for the appropriate things you need to screen for. Looking at what are the top comorbidities that our patients get as they age: hypertension, diabetes, hyperlipidemia, coronary disease, counseling them on lifestyle modification. So the biggie that I get on my soapbox about is cigarette smoking, because the combination of tobacco use and HIV is a particularly deadly combination. Exercise, diet, all the things that we would do, that we should be doing ourselves to keep ourselves healthy. So that's kind of where I start. And if you're not comfortable, and I put a plug in before about primary care, but if you're not comfortable, then I think you need to work with another practitioner who is comfortable helping you co-manage these patients.
Another screening point to mention, at least in the context of viral hepatitis, because that was part of my vlogs, is obviously screening for hepatocellular carcinoma. And I think that's really, really important, because we forget that even if you have hepatitis C and you're cured under easy to take oral DA therapy, it doesn't mean if you had a cirrhosis, you're still at risk for HCC. And we just had several patients the last 6 months who came in after a year or two after they finished their DA course and presented with HCC. So that's something to keep in mind. And then remember that for hepatitis B, if you're Asian or older age, you may have some risk factors, and your family runs HCC, you may also have to be screened even in the absence of cirrhosis. So just that you know that there are other things to think of in the context of viral hepatitis co-infection.
And I would also put in a plug for vaccination as important prevention. Many of our patients have not been vaccinated, are not up to date on vaccinations. I get a lot of patients here in Florida who have never been screened for hepatitis A, B, and C. So I think those are really important things to do, and then vaccinating people who need them. Tetanus shots. Nobody is up to date on tetanus shots.
Okay, so Teresa asks, are you concerned about the increasing percentage of fatty liver disease in persons with HIV? Dr. Grossman, why don't you take that one?
I am, and especially as people start to gain weight, we see a larger percentage of people with fatty liver disease. Diet becomes a big issue. We don't really have a lot of great interventions for vitamin E. There aren't a lot of great interventions for fatty liver disease in many people. Of course, fatty liver disease can lead to liver injury and cirrhosis, and I've had patients who needed liver transplants just from the evolution of fatty liver disease. So this is not a benign condition, and I think it's something that we really need to focus on with patients, certainly with simple things like diet and exercise, to emphasize how important that is.
I think this is an underdiagnosed condition, and I think the data that I've seen in the United States, it's rapidly becoming the most common cause of the need for liver transplant. So, yeah, I think we need to be really aware of that, and in particularly, as Dr. Grossman said, in our patients who are gaining weight. Yeah.
So the liver transplantations for NASH are increasing basically also because hepatitis C is so well treatable now, and so the number of people who used to be transplanted for hepatitis C are obviously disappearing. I have to say, though, that if you go into the literature, it's very complicated because we don't have great tools for assessing fatty liver disease, and the true assessment for NASH still involves a liver biopsy, which everyone obviously reluctant to do. So we now have non-invasive methods like CAP measurements, which is like the FibroScan, which you may know for fibrosis assessment, and you can then sort of measure the fat content, which gives you an indirect measure of is that increasing or not, but only in the presence of fibrosis is really going to lead to more meaningful disease, and that's then when it becomes NASH in the setting of having fibrosis plus inflammation in the liver. But that, again, is a histological diagnosis. And the studies looking at CAP measurements say that probably 10, 15, 20% of our patients have abnormal high fat content, and that's very difficult to judge on because a lot of that is a result from past antiviral treatments, including DDI and D4T and drugs, which were known to cause fatty liver disease in a certain way through mitochondrial damage, but we're not using these drugs anymore. So the question is, how is this all going to evolve? And we have an own study where we're looking at CAP measurements and fibrosis scores, but through FibroScan measurements in HIV infected who do not have viral hepatitis co-infection and do not have alcohol abuse. And over time, we see an increase, and around 15 to 20% develop significant fatty liver. And that is related to increase in BMI, to diabetes. And indeed, the question is that then eventually also going to be a consequence of some of the antivirals we're giving where we see more weight increase? And I think that's the big question in the end, is the weight gain we see under modern antiviral therapy eventually going to cause that? But on the other hand, we also know that, for example, just having the COVID epidemic has led to more weight increase because people move less, they're more in self-isolation. So there are many other factors which contribute to weight gain. People who start antiviral therapy in 2020 on average have a higher weight than they had 20 years ago. So, there are other factors that makes the whole discussion very complicated. So I think we're just at the beginning, but since a lot of companies have put a lot of investment now into developing drugs for fatty liver disease, I think we're going to see more options. And with that, I think more research and data, which will give us a little bit more background of how the fatty liver story is going to evolve in HIV-infected individuals.
So, Dr. Rockstroh, if I could ask, right now, given where we're at, what's your trigger for ordering a FibroScan in somebody with fatty liver disease?
Yeah, so if I have someone where I have fatty liver disease, I would always do a FibroScan just to make sure that he doesn't have fibrosis, because if he has fibrosis, it might be a NASH patient, and then you would have to do a liver biopsy. And I can tell you, for example, I get a patient from a primary care provider who has someone who has always just a little bit of elevated liver enzymes, but the platelets are only 40,000, which is sort of an indirect marker from the lab, which tells you that there might be advanced liver disease. And indeed, when I did the FibroScan, it was already 20, so it's already clearly suggestive of cirrhosis. And that's the problem. So if you have fatty liver disease and fibrosis develops, then that gets into NASH, and those are the candidates for liver transplantation, and where it gets into a much more worrisome clinical outcome. So that's why in anyone who has a tendency to develop more severe fatty liver disease, let's say you do an ultrasound, have the feeling it's a really fatty liver, then I would at least do a FibroScan to make sure that there's not also underlying fibrosis, because the combination of the fibrosis with the fatty liver is what goes into NASH direction and is harmful.
And how often would you repeat it if if they weren't in that situation?
Yeah, well, that depends a little bit, but so a lot of people, obviously in our study, they're all in the study protocol, so everyone gets annual FibroScans, but I don't think that you can really promote that in that way. But at least if there's at least one, and then you also see in the lab, if the platelets are always normal and albumin is always normal, all these other non-invasive markers. Think of APRI, which you can easily calculate from a liver enzyme and platelets. Then if that's all fine, then I think you don't have to worry.
Thanks.
Thank you for that discussion. So Eugene asks, how frequently do you see patients like those you discussed here in your practice, either in person or by telemedicine? So what's your follow-up approach as your patients are getting older? Is it different? And how are you incorporating telehealth these days? So Dr. Grossman, why don't we start with you?
Well, we used a lot of telehealth during the worst part of the COVID epidemic in last spring, but then we went back to in-person visits. I'm not sure, as things get so much worse in the U.S., if we might be doing more telehealth again. I tend to see, it really depends on comorbidities, on other things. I mean, I tend to see my particular case, the people getting gender-affirming hormone therapy. I tend to follow them every 3 months, with certainly for the first year. And then, as people move on, if they don't have any other comorbidities, I may see them a little bit less often. And certainly with people with HIV, we used to see them every 3 months. That was just sort of standard. And over time, we've moved that to 6 months. There are some facilities that see people once a year. If HIV is their only problem, I still feel more comfortable seeing my older patients with multiple comorbidities every 3 months who have HIV. It really depends on that.
Yeah, I agree. For many of my older patients, HIV is actually the least of their issues. And so if it was just the HIV, I agree, I'd probably be seeing them, once or twice a year. But it's really the hypertension, diabetes, hyperlipidemia, osteoarthritis issues that bring them in more frequently. And most of those patients I'm seeing every 3 to 4 months.
And, I can't forget that a lot of my older men are having a lot of sex. And so I'm bringing them in every 3 months just for STD testing.
Yeah, so I would agree. I think it's not about HIV control, but it's like if you have diabetes and hypertension, you want to make sure that the kidney is still doing fine. You want to make sure that the HbA1c is okay, that they're taking their medication regularly. And you're right, in the setting of hepatitis C, in particular with the high reinfection rate, you want to make sure that there's no new episodes. So STD screening, I think, remains an important part of our service as well.
On the telemedicine thing, though, I think many of us are starting to combine some telemedicine visits with some in-person visits. So, especially depending for people who are geographically challenged and have to travel a long way, to make that a little bit easier.
Great. So Evelyn asks, what are your thoughts about long-term testosterone replacement in this population? So Dr. Appelbaum, do you want to start with that one?
So long-term testosterone, I guess I'd want to know, is this for gender-affirming hormone therapy, or is this for low T, or for just sort of minor feelings of low energy, low sex drive? So I'd have to know a little bit more. Certainly for my trans men, I'm using testosterone. I don't, at this point in my practice, have any, 70 or 80-year-old trans men, so I haven't crossed that threshold yet. For low T, if it's documented, low testosterone, and they have symptoms to go along with it, absolutely. I am a little reluctant for sort of the folks who come in, have sort of non-specific symptoms and may have a normal both free and total testosterone. I'm not prescribing testosterone.
I think it's the testosterone therapy in older men continues to be controversial. I think we all learned in medical school that it would stimulate prostate cancer. And I recently reviewed the literature on this because I have a patient who had prostate cancer who's arguing with his urologist about it because he insists on staying on testosterone. And actually, he's right. It's still very controversial. There's really a very mixed bag of evidence about whether this is a problem or not. And, I think we have to go back to basics to figure out what's going on.
Okay, and there's a couple of specific questions based on your video logs. So Craig asks, is switching ART therapy more complex when making a switch for an aging transgender patient? So Dr. Grossman, since that was your vlog, we'll start with you.
I don't know that it's more complex. I think, again, you're dealing with drug interaction. And, for many of my transgender patients who are older, who are on hormone therapy, our primary medication is integrase inhibitors, and those don't really seem to have a lot of interaction, and that makes patients feel very safe. But I think, again, it's just the drug interaction issue that makes things a little bit more complex. I do think that it's very important for this population to tie the HRT to their HIV medication. I think you get a whole lot more buy-in when people know that you can support their gender affirming therapy. And it really is easy medicine. I'm not sure, Dr. Appelbaum does it, I do it, Dr. Rockstroh, you're shaking your head, I guess you do it too. This is not complicated medicine to do gender affirming therapy. And I think, Dr. Appelbaum and I both worked at Fenway in Boston, and every primary care provider at Fenway was expected to understand how to do this therapy. And I think that should be universal.
I can't agree more.
Okay. So we inevitably get questions on the COVID-19 situation, and we have one on the COVID-19 vaccine. William asks if HIV positive patients are likely to be considered a priority. I'm not sure that you'd have insights on that, but maybe can you talk about what we know about how patients with HIV might respond to the vaccine, particularly older patients with HIV, and if there's any concern there when that vaccine becomes available. So, Professor Rockstroh?
I can actually tell you that HIV advocates have been pushing very, very hard to get people with HIV, living with HIV, involved in the trials, and multiple companies have agreed to include people living with HIV, where at first it was an exclusion for most of these trials.
Yeah, so if you think of the primary or the press release from Pfizer and the German company yesterday on the new vaccine, which was a very interim analysis, they did not present any data on age distribution, and so I think we're left with, they say there is more than 90% effectiveness, but we don't know, is this true for every patient group? And obviously questions are, is it going to be the same for patients who are older, because we do know that vaccine responses in older patients are not as strong as in younger patients, and so that because that leads to questions: are 2 vaccinations enough? Would you need a different dosing schedule for older patients? So I think there's some open questions there, and I really think we need to see a little bit more data. Obviously, older patients are a vulnerable group, and in the general population, like pneumococcal vaccinations are recommended for people from a certain age onwards. They're recommended for all HIV patients in general, but there will be a stratification, I'm sure. I don't know. There's a lot of discussion currently, at least in our country, ongoing, like which groups are going to be vaccinated first, and clearly the elderly are one. HIV patients so far, I think, have not been raised as a point, but you would at least, if you follow the discussion of does HIV have an impact on the course of COVID-19 disease or the outcome of COVID-19 disease, then when we think of the first reports, the first 5 patients from Barcelona and then from the different American cohorts and from China and so forth, it looked as if there was not too much difference in the outcome of HIV-infected individuals with COVID-19. And then we saw 2 cohorts from the UK and 1 from South Africa, which really reported a less favorable outcome and a 2.3-fold higher mortality rate in African HIV patients with COVID-19, and then a 1.6 in the UK. There was, though, a big overlap with tuberculosis in the South African cohort, which makes it very complicated because you sort of, tuberculosis is an old driver of all bad things. And so I think you can't just transfer the African data to, North America or Europe. So I think it's a little unclear, but they have clearly much higher prevalence of HIV and such much higher cohorts to follow. And it doesn't help to look at 33 3 patients and say they're doing equally good or not as good, because you may have a bias because you only include 30 young patients. So that's where it gets complicated. But I think older patients, just because of their increased probability of having comorbidities which have been associated with a worse outcome like diabetes and so forth, I would be thinking would be among the first groups to be vaccinated.
Truthfully, I have so many questions about this Pfizer vaccine. So how long is this going to last? Will there be any side effects that are seen later? This is the first messenger RNA vaccine that we've seen. And it needs to be kept at, I believe, minus 70 degrees, which is also going to create huge logistical problems. So I am telling my patients that this is very encouraging, but given everything that's happening around the world, they need to double down on the current protective things that they're doing to stay safe over the next 6 months at least or more.
Thank you very much, Dr. Appelbaum, Dr. Grossman, and Professor Rockstroh, and thanks to our listeners. If you would like to view the short video logs on specific patient cases recorded by these expert faculty, visit the Clinical Care Options website by clicking on the link in the show notes. Be sure to check back regularly for more episodes on important infectious disease topics. Thanks!